Behalf of Rachel Grosser, who's actually one of our research assistants. This is essentially her work and actually her slides. She was unable to make it at the last minute today. She's matriculating into medical school in 2 days, and she really did a fantastic job. I'm essentially just here presenting in her stead. This is our initial experience with minimally invasive esophagectomy at a major cancer center, and just experience of our first 100 cases. I do have no disclosures. As we know, minimally invasive esophagectomy, as we've heard much about at this meeting, has had increased utilization and a fair amount of data now, including a prospective randomized trial showing improved perioperative outcomes. However, when it comes to introduction into practice, there are many good experiences out there showing it can be done safely, but the actual process of introduction has not been well described, at least to my review of the literature. The objective was fairly straightforward, was to describe the process of introduction and initial experience with MIE in a high-volume group practice. The plan of introduction was in some phases, and I'd just like to acknowledge actually the long-term planning on the part of my previous chief, Dr. Valerie Ruch, who really had the vision and foresight to plan this out over some years, not to sort of just jump into this. The first phase was actually a discussion early on in 2009 to assess the validity of the procedure, which essentially was sending a fellow, naming myself, to Pittsburgh as part of my elective time there to assess the procedure. The second phase was formal training and hire, which he felt strongly about, not starting the procedure de novo, but actually getting someone formally trained in the procedure, so actually a full fellowship in the procedure. And then finally, the third phase, returning to the institution and disseminating the technique to the rest of the group. So to her credit, this was a plan over about a 3 to 4 year span. The methods of implementation to practice, and I'll really be talking about the dissemination portion of those 3 phases, the staff education of the nursing staff as well as all ancillary staff involved with the case, the anesthesiology team. And it was very much a team collaborative approach between all the esophageal surgeons on the service, with 2 attendings on every case to maximize patient safety and to give the program the greatest chance of succeeding. There was a consistent trainer and rotating trainee for every case. Initially 6 participating attendings, and through the process down to 2 who were really dedicated to the procedure to continue on with it. Initially this was a high priority on hybrid procedures and was designed that way. So we would look over every procedure and decide we were going to try a full ME. Was the trainee comfortable with that, and how far did they want to go with the procedure? By and large, we put a priority again on hybrid procedures initially in the experience with predefined conversion points, mainly excessive time, failure to progress to the operation, but most importantly, if there was any perceived or real departure from the comfort zone of the trainee who was doing the procedure, essentially was their patients being operated on. The procedure, I won't belabor too much. This has been described in great detail in many areas. Essentially, again, retrogastric dissection, conduit formation, hiatal dissection, greater curve dissection, pyloroplasty if opted for, or in some cases Botox or no pyloric emptying procedure. And these were by and large Ivor-Lewis procedures, although there were some McEwen as well as transhiatal and colon interposition. These were by and large also stapled anastomoses with the EEA 28 stapler. So results during the inception of the program from 2010 to 2013, 312 esophagectomies were performed in total at the institution. 100 of these were approached as an MIE approach. The median age was 60 years. 77% were male. 85% again were Ivor-Lewis, with a scattering of other resection approaches as well. Again, 85% of these, and these are our standard numbers that we would see in any of our sort of esophageal experience. For the overall experience, 85% were adenocarcinoma. Most of our patients undergo induction chemoradiation, and here's the pathology stage outlier. Obviously, for the stage 0s, most of these were stage 3 patients prior to induction chemoradiation by clinical staging. The perioperative outcomes were very much in line with our open experience and with other experiences of MIE, and there's nothing spectacular here. Estimated blood loss was low. The lymph node count was certainly adequate. The length of stay, about 10 days for the initial experience. 81% had a complete resection. 14% did experience a major complication, graded again by the common terminology criteria for adverse events. 10% did experience a grade 2 or greater anastomotic leak, and there was a 3% 30-day mortality. As far as hybrid procedures and conversions, 11% of these were planned hybrid procedures, 10 with abdominal laparoscopy and 1 with chest thoracoscopy. That was the colon interposition, where the chest dissection was done with a minimally invasive approach. 24% unanticipated conversions to open. None of them were emergent. 14 in the abdomen and 12 in the chest. The reasons for conversion very much were in line with our predetermined endpoints. It was felt excessive time was being taken. We had defined that as 2 standard deviations from the norm. That was sort of a loose endpoint. Poor visualization, technical difficulty during the procedure, the extent of disease, and these are listed in decreasing incidence. Performance of the anastomosis of the pyloroplasty early in the experience. Many surgeons were not comfortable performing these portions of the operation, minimally invasive or approaching it that way. Adhesions, and then 1 iatrogenic small bowel injury in the abdomen during lysis of adhesions that was repaired with a small mini laparotomy. As far as complications, overall grade 3 to 5, 5 being death with 17%. And here they are. The major ones that I call your attention to are TE fistula, gastrobronchial fistula, which have been previously described in the sort of robotic experience, which does overlap this experience as well. The anastomotic leak, greater than grade 2, was 10 patients, 10%, and grade 5, death, 3% again, and 1 patient with acute respiratory failure from ARDS, 1 MI leading to death, and a respiratory failure as well from advanced pneumonia, aspiration and pneumonia. If we look at the results from Inter-Quartiles, so for every 25 patients, we see decrease. Well, I will just first say that this is somewhat confounded by the fact that we did start a robotic experience here in the 2nd quartile. That's been described separately, but we do have an increase, obviously, in the robotic component of the minimally invasive procedures. There's a high number of hybrid procedures in the 1st quartile, which essentially disappeared afterwards. Conversions decrease over time, with none in the last quartile. Median OR time does decrease as well. Lymph nodes increase with the minimally invasive experience, and the length of stay decreases over time, although this is very attending dependent, and I think post-procedure pathways have more to do with that than the actual procedure itself. Major complications decrease over time, and the leak rate and death rate is essentially stable. Initially in the experience, as I mentioned, 6 attendings participated with a consistent trainee, which is an interesting way of putting it, since the most junior person is essentially training the more experienced surgeons, but in just a technique, not the operation. A consistent 2 attending team was adopted in the 2nd quartile, mainly with the advent of the robotic program. So there are significant limitations to this data. It is single center. It's observational for the most part. It's retrospective, although this was kept a very close record of prospectively throughout the experience. It's difficult to translate to other experiences, and the change in technique, meaning the change to a robotic approach, and the team also confounds the experience as well, where the experience became far more focused to a more limited number of attendings on the service at one point. However, in summary, MIE was successfully introduced into a high-volume practice with minimal variation in quality and outcomes. Key programmatic points we felt were pre-initiation preparation, which was extensive, including formal external training and planned dissemination of the experience to the other members of the service. Adherence to predetermined conversion points, collaborative team approach was paramount here for the success of the program, and a primary priority on patient safety at all times, with formal critical evaluation of the experience to be sure we were within our quality norms. And this initially started out as a quality control measure of our experience to be sure we weren't causing harm with the operation. In conclusion, in our experience, adherence to a paradigm of stepwise and controlled introduction of new technology was paramount in the process of integrating into practice a major operative technique change while maintaining patient safety and outcomes. Thank you very much. I am not Rachel.
We have time for maybe 1 or 2 questions.
Hi, Mr. Rodriguez, Dayton, Ohio. 2 quick questions. I noticed that your length of stay is as low as 5 days. I mean, you do your contrast study, your length of stay is as low as 5 days. You do your contrast study day number 4 and then try to discharge them the next day. How you achieve, I mean, my length of stay usually is like 7 days. That's our protocol. I'm trying to wonder how you achieve that 5 days.
I'd say that the post-operative pathway was the most variable portion of the experience, which varied from attending to attending, and even from the 2 attendings performing the most minimally invasive esophagectomy, it was quite variable. From a personal preference standpoint, if they're doing fine at 5 days, I remove the NG tube, do the swallow, and send them home on 2
So
feeds.
you contrast study day number 4 and then
Day 5.
day 5, and you
Yeah.
discharge them there
The
right
reason
away,
is, and discharge the same day if they
okay.
have
And
no indicators of any problem.
Any readmissions from those patients, or you discharge them with like a full diet or a
No,
post-gastrectomy
they are
type of
discharged
diet?
on 2 feeds and on liquids, and I allow them to advance their diet at home with close follow-up from my office, and the readmission rates are no higher than the open patients.
So when you say follow your office, like phone calls from your nurse assistants,
Correct.
calling them to see how they're doing,
Correct.
things like that?
Often we find ourselves just following a perfectly healthy patient as they advance their diet in the hospital, waiting for a leak to occur.
Okay.
We have a drain that is laying next to the anastomosis, a JP drain, very similar as you've heard with other experience from the Pittsburgh group,
Okay.
that will identify those leaks and generally keep those patients safe from harm if they do develop a leak. And they have very good instructions as what to do
What to do.
if any characteristic of that drainage changes over time.
Dr. Bora?
Okay.
I truly enjoyed your talk very much. As we all know, the key to this operation really is the intrathoracic anastomosis. The laparoscopy, for the most part, can be done, even working with bariatric surgeons, et cetera. But the key really is the intrathoracic anastomosis. And so from your experience, and it's vast, can you tell us the advantages of the EA versus the GIA, et cetera, and why you guys chose to sort of use that and champion that in your series and your patients? Thank you again, Netu.
No, thank you, Fez. Very good question. I think, number one, it's a matter of culture, what you learned, what you're used to, and I think any of those anastomotic techniques have been well described and well done by different surgeons, so it's really dealer's choice. One caveat we have maybe against the linear staple technique is that we do feel, and I can't substantiate this, that the margin is perhaps compromised in those patients where you do have to retain a larger length of esophagus in order to complete that anastomosis with a linear stapler. So for that reason, we do prefer the circular stapled, and then we do that on our open cases as well. So it's no different. We haven't compromised or really altered the technique or the internal operation at all. We felt that would be one of the indicators to say we should perhaps abandon MIE if we're changing the operation and the quality measures of the operation. But I don't have strong feelings about the anastomosis one way or the other.
I have one last question, Nedu. The R resection, you had 81% R0. What's your sense for why you were getting positive margins in 19%?
I think that is, we make a pretty high anastomosis. Now, for the hybrid procedures, where some of these R0 resections were, it's difficult to say because the chest was done open for the most part, and these were abdominal laparoscopy as we were getting used to the experience. But I think about 80 to 90% is the norm for what you see post-induction chemoradiation. It falls into the 70 to 80% for induction chemotherapy. And we are seeing rates as high as 90% now in our experience, but I'm not sure that falls too far out of the norm. It's usually microscopic R1 resection that we're seeing, rarely R2.
Thank you.
Do
We have to move on.
do you find most of those are circumferential margins, the positive, and not the distal and proximal margins? That's what we find in our...
Most likely usually the proximal.
The circumferential margins,
Thank you.
there's a limitation.
We're out of time. Next.